housekeeping announcements. Thank you, those in the room already, for joining us for our third New Horizons in Science session. This one on the unequal burdens that COVID-19 and this pandemic has been placing on people of color and indigenous people in this country. Our guests today are Spero Manson from the University of Colorado, Denver, Anschutz Medical Campus, David Hayes-Bautista from UCLA, and Mary Bassett from Harvard, all of whom have specialized in doing research on the effects of the disparate health effects on various races. I hope you've had a chance to see the video that we posted of their presentations. You can find that in the video gallery in Hoover, along with the videos for all the other New Horizons talks. Do be sure to check it out if you haven't seen it yet. And now we have the opportunity to interact with them live and post some questions. So please type your questions into the Q&A in Zoom so that we can see them. Go ahead and do that now. And let's begin, Mary, with you. Now you have, in your presentation, you presented some results that you published in June in a white paper, but now you have a preprint out. October 6th, I believe it came out. And can you find that on, I believe, medRxiv, is that right?
That's right. And
there's a link to it in the recorded presentation. But there you looked at poverty as another dimension, in addition to race, that is sort of a distinguisher on the impacts of COVID. Can you tell us a little bit about what you found there?
Sure, thanks, Wade. And I'm happy to say that the June paper has been accepted and posted now on PLOS Med. And it's on a slightly expanded data set, but it showed the same extreme excess mortality rates among Black, Latinos, and indigenous people among younger people. So let me see if I can share my slide. Did that work?
Yes.
Do I have it the right way? Is it a big picture?
It is now. Yeah.
It is, okay. I don't need to swap views. So this is, I talked about, at least I hope I talked about the fact that the federal data have been slow in coming and on mortality. It wasn't until May that the federal government released race data by COVID death. Before that, we only had age and gender, and we still can't look at age, gender, and race separately. I'd love to see whether there are gender differences by race, for example, race ethnicity, for example. And another thing we haven't been able to look at is markers of income. That would include occupation, educational attainment, because these data appear on death certificates, but they haven't been released by the federal government. But there was one jurisdiction that Justin Feldman, the first author on this preprint, found, Cook County, Illinois, that's where Chicago is, where we were able to get matched census tract of the decedent and pull down census data. So these are area-based measures of income and then individual measures of race, ethnicity. If we had death certificate data that were more fully released, we could get both of these measures at individual level, but area-based measures have been shown to be quite robust. And what I don't know if you can see my pointer. Can you see it? No? Can you see it here? No? All right, if you look at the middle picture. So these are,
it just came up.
You can see it. Okay, so at the top, this is all age groups. These are white, these are Blacks or non-Hispanic Blacks, and these are Latinx population. And what you can see is the height of the bars shows the age-adjusted and gender-adjusted mortality rate. But these quartiles show census tract poverty levels using the poverty line. So the percent of people below the census tract is highest in this dark bar and lowest in this bar. And in all race groups, you see a gradient by area-based poverty, so that people who live in the wealthiest neighborhoods, regardless of their race ethnicity, have the lowest have the lowest COVID mortality rate for their race ethnic group. And if you look at people under the age of 65, which is a pretty big group, but it mostly includes people from 20 to 64. We don't see deaths in people under 20, or at least not many. You can see that among whites who lived in the poorest neighborhoods, that their mortality rate is about the same as Blacks who live in the poorest areas. And in this data set, the mortality rates are highest for the Latinx population, which is an important thing. I think this has been shifting over time. But this is an important thing to highlight, I think, because we all need to think about how racism works. And one of the ways that it works is to distribute people of color into lower income groups, higher poverty neighborhoods, lower levels of educational attainment. And if you look at whites who live in similarly deprived areas, their mortality rates are high too. Although we don't see protections among Blacks who are in the highest income groups. So I think that it's very much embedded in US, particularly US thinking, that these ideas of these race ethnic groups are somehow very fundamental to human beings, and that they independently determine whether your risk of health and longevity. But it works through concrete mechanisms, and an important mechanism through which it works is poverty. When you find whites who are equally poor, or their neighborhoods rather are equally poor, they have high mortality too.
Spero, did you want to add something to that?
I do. Thank you very much, Mary, for presenting this and those insights. I'd also like to underscore the fact, particularly for this broader audience, that data has its own prejudices and biases. That in fact, if we looked at the nature of trying to search for similar kind of data with respect to American Indian and Alaska Natives first, only 23 out of 50 states collect those data with that designation. Secondly, over 72% of American Indian and Alaska Natives live in today's cities, either the urban or suburban areas, and thus are often aggregated under other racial classifications. And thirdly, the designation of race ethnicity is really fraught with difficulties for American Indians and Alaska Natives because of well-known problems of racial misclassification. So the data that we have is highly suspect. Even the CDC acknowledges that there are particular limitations with respect to certain segments of our population. So while I applaud the availability of these data and the extent to which it can inform our efforts, I want to underscore the fact that such data are differentially available across our different segments of society.
I think in the paper that I just mentioned has been published by PLOS Med, every single one of our graphs on Alaska, on the American Indian Alaska Natives, the federal designation, has an asterisk next to it to indicate the fact that these data are unreliable. And I want to thank you for raising it. There's a real need to improve the quality of these data.
David, there's a question here from Salar James about the report on the shortage of Latinx physicians that your center, well, a center at UW actually has put out, but
I'm going to get rid of this. Let's see.
Your center at LA also has studied this. What have you found?
Okay, well, in fact, I shared these data with the University of Washington with their newly developed Center for Latino Health. Here's the national picture. Can you all hear me?
Yes.
Okay. As we look from 1980 to 2010, this top line is the number of non-Hispanic white physicians per 100,000 non-Hispanic white population. You notice that has gone from 211 to 315, going up every decade. For Latinos, the number of Latino physicians per 100,000 Latinos has gone down from 135 to 105. Interesting. And let me see if I can get the next slide down. There. Trying to get the next slide. I seem to be stuck here. Well, I'll just do this one. Here are the numbers. As we look at the almost 15 million non-Hispanic whites in California, 15 million Latinos, about the same number, 60,000 non-Hispanic white physicians, 7,000 Latino. Basically, for Latinos to have the same access just by availability as non-Hispanic white, we are missing 54,000 Hispanic physicians. And the rate at which all the schools in California, both public and private, graduate Latino physicians, it will take 500 years to create those 57,000 Latino physicians. So Senora Gomez has a temperature, she's got a raspy cough, she runs to follow the advice, go see her physician. Oh, Senora Gomez, you want to see a physician? Well, take a seat and the physician will see you in 500 years. And if we're talking about language, it's equally as bad. As we look at the physician labor force by language in California, some language groups are very well served per 100,000. Farsi, Hindi, Korean are very well served. English is sort of, if you will, the comparison, 344 English-speaking physicians for every 100,000 English speakers. Then we have some shortage languages, Vietnamese, Thai Lao, Filipinic, and way at the bottom, Spanish. And before people jump to conclusions, I need to remind people that medical services have provided in Spanish in California every single day for 251 years. This is not something new. So we've had these issues in terms of just the supply. And for the first couple of months of the pandemic, if you remember, you actually had to get a physician's recommendation just to get a test. So you can see why it took a long time for Latinos to get into the data system. Didn't have the physician, didn't have insurance, didn't get the test. Wasn't until they walked into the emergency room with a full-blown case of infection that they start to enter our data systems. So I'll just leave it at that.
Thank you. Yes, Spero, well, so you can add to that, but I also want to ask a question of you that you can answer, which is whether the IHS has any better health data on Native American and Alaskan Natives that we reporters can dig into.
The answer is no, because it comes from basically the same sources. It puts out reports, but it's all rooted back in the original reports to the CDC on a state-by-state basis. And I think Mary's paper pointed out earlier for remarks is that there's enormous variability among the states, or perhaps one of your questioners in the chat box, there's enormous variability among the states in terms of the quality and comprehensiveness of that data. So I think David's point is spot on, but let me provide you with a slightly different view of it with respect to the American Indian and Native circumstances. We would be happy with any physician. Over 30% of all of the positions in the Indian Health Service, that either physicians or other primary care providers, are vacant. And you know, we would take anybody, much less those who are affiliated with our particular tribal communities or conversant in our cultural and social lives. So while David's point is extremely important, I want to underscore the enormous paucity of such resources within American Indian and Alaska Native communities. And just as David pointed out, in the circumstances of Latino and Latina populations, the implications of that for access to even primary care, imagine what the vacancies imply for the constraints on access to primary care among Native communities.
Right. There's an interesting question here from Alan Boyle about the coming wave, which we're seeing is starting to build now in the United States. We've been through arguably two waves. And Mary, you were mentioning at the outset here that we saw a difference in sort of racial impacts between the first and the second, with Blacks hit harder in the first and Latinos more in the second. What are your respective expectations for what is going to happen in this next winter wave of COVID?
Well, first of all, I'm not sure that we've been through two waves, but that aside, the data, I mean, we're still in the first wave, and now we may be in for a further boost. So the data show, and I may not be the best person to talk about it. I don't know how to explain it, but the data show that there has been rising mortality relative to whites among Latinos over time. So that now when we look at the rank, you know, not that this is a competition anybody wants to have happen, and it shouldn't be happening. Latinos now have the highest mortality from COVID, according to national data, in every age group. so across the lifespan. I'm not sure how to explain it, but what I start thinking about is just the two things: the precarity of work for many people in the Latinx community, you know, highly represented in domestic work and in food service work and other types of essential jobs, building, you know, maintenance, cleaning, and so on. That these are jobs that, you know, people don't have sick leave, they don't have their wages are low. And then of course the housing crisis means that people live in highly crowded apartments, often multi-generational. These are the things I start thinking about, but I'm not the expert here. I hand it over to our expert.
David, you want to comment on that?
Yeah.
Certainly. In fact, you may remember in about the first month of the pandemic, people thought this was a rich white person's disease because that's where it was originally transmitted via international travelers who had the sufficient time and money to go abroad, travel, be exposed, bring it back. But then it quickly changed. And particularly in California, because Latinos tend to occupy a lot of the occupations that are essential for the state to function, but we're not considered on a same par with physicians and nurses. We spend a lot of time in the hospital teaching physicians and nurses, donning and doffing all the safety equipment. We didn't think at all about the farm workers. And the farm workers travel in huge crowded buses. They work shoulder to shoulder in the fields. They don't have the option of growing strawberries in their front yard, in their front room. The packing house workers, we've seen how COVID has just ripped through because they have to work closely together. In the food industry, the grocery store checkout clerk who is exposed to 300 people per shift, and the stores, many stores are still not providing PPE. In construction, mechanics, the bus drivers, all these occupations that hold the system together so that the higher income could afford to stay at home, telecommute, take their kids out of school. Even before COVID, because of housing prices, Latinos in the latest consumer expenditure survey have one more person per household compared to white. Latino households, by the way, have 60% more wage earners per household because they're out there working. So it's that very high work ethic that helped produce, by the way, the world's 8th largest economy for 2018. Also means more exposure to COVID. Therefore, that will translate quickly into more cases and more deaths, even without factoring in the physician shortage, the lack of health insurance, the low wages that are paid, etc. So it's like a perfect storm hit. Different from chronic. This is a communicable disease, and it shows the disconnect between Latino communities and the formal public health structure. Just a real disconnect.
So let's pivot a little bit to forward-looking, applying lessons learned from previous pandemics and or previous epidemic outbreaks, and also from this earlier stages of this one. Spero, you talk in your talk about how tribes have learned that they really need to exert their sovereignty and to sort of control public health on their own, because they can't rely basically on the larger society outside to do it for them. And you gave some examples of how certain Native American groups have tried to, for example, shut themselves off and bar access. How's that been going, and has that been working and helping?
Well, there are two parts to this. I'd like to begin first, if I may, Wade, by pointing out in terms of what our audience, science writers, and some of the implicit assumptions that frequently underpin the kinds of questions that are asked of our people. First off, for the most part, most of the questions we initially get, and I'm sure all of us on the panel today are getting multiple questions daily around this. The kinds of questions I get about COVID and the risk and the consequences from science writers is basically got 4 basic assumptions built into it. One, it's always problem focused, okay? What's the nature of the problem? And how are you dealing with it? What's its magnitude and what's its consequences? And that's in fact been, up until this moment, the primary focus of our remarks. I think we believe, spinning from your particular question, that in fact problem is important, but there are many local solutions that are underway that build upon the resources and the resilience within American Indian and Alaska Natives, either separately or conjointly with our supporters in the broader non-Native world, in particular biomedical providers. The second major thing that we often encounter is that we American Indian and Alaska Native people are so unique and esoteric, it immediately attracts the science attention and of science writing. And there are many aspects of our lives that overlap exactly with those of the populations that David and Mary have been talking about. Yes, indeed, there's some unique aspects. You raised it and gave some examples a moment ago. The third is, and the examples I gave in my talk about the Cheyenne River Sioux and the Dene or the Navajo were indeed reservation-based. But when most science writers approach me, immediately the frame that they have is asking and thinking about is in terms of reservations. And in fact, over 70% of we American Indian Alaska Native people live in our cities and suburbs. So there are important and often unique issues that we face there. And then lastly, I want to point out is we're frequently, in the context of the previous pandemics I talked about in my presentation, you see this overwhelming blame the victim dialogue. And the kinds of questions I usually get from science writers has to do, well, what are the vulnerabilities of American Indian and Alaska Native people that make you particularly susceptible to the compromises that this particular crisis has introduced into your lives? Well, I would submit that anybody, native or non-native, living in the environments and circumstances in which the majority of us do, as Mary was pointing out in regards to poverty, would have exactly the same level of risk. So it's not something internal to us. It has to do with environments that we live in that pose that added exposure to those risks that lead to such consequences. So it's in the face of that, not surprising, that American Indian Alaska Native people have turned to the things that we can control. And many of those aspects are embodying the fact of tribal sovereignty, and the fact we're codified in law, that we can impose these kinds of restrictions, bring to bear these kinds of resources to addressing these issues and problems in our own terms. And I think there are many remarkable examples of success in doing this, sometimes in partnership with our non-native communities and states, other times despite the entities that frequently characterize those relationships. And I think there are many lessons to be learned that not just relevant to Native people, but I think can generalize to other segments of our society.
Great. David, in your talk, you focused on framing and how framing has been a really problematic way that the media have covered Latino issues and populations. How are we doing in this current crisis? Any better or worse? Or?
All I can say is particularly the media in English are continuing in a 170-year tradition here in California. Going back to the gold rush, 1849, I read newspapers both in English and Spanish during the gold rush. The same thing. In English, these Latinos are foreigners, although they were here first. They speak the wrong language. They're criminal. They're dangerous. They're lazy. They're drunkards. Los Angeles Times in the 1890s used to call Latinos in their headlines cholos, pochos, all sorts of peons, all sorts of derogatory terms. So there are this notion somehow Latinos are not American. Somehow we were never here until about 20 years ago. Then I read the Spanish language media, and it's like I stepped into an alternate universe where, you just have normal families and teams win the local little league, and a lost puppy gets found and a singer comes to town. And I sometimes wonder, particularly when I read the LA Times and La Opinion, these are published in the same city. And in fact, for a period, LA Times owned La Opinion. So the current framing, and that's consistent, Latinos are always immigrants and foreigners. In fact, since 1790, the average Latino in California was born here in the United States since 1790. And right now, about 70% of Latinos across the country are born here. But calling us an immigrant is a nice way of sort of foreignizing, otherizing, etc. Hey, we're born here. We speak English. We hold jobs. In fact, Latinos created the world's 8th largest economy. That's in our Latino GDP report. Highest labor force participation, lowest welfare utilization, strong families, set up a lot of businesses. Oh no, you're immigrants, you're foreigners, you're criminals. That's the framing. So it's been going on for 170 years. I would hope, particularly now the LA Times has had its editorial room meltdown, this might be an opportunity to actually go out and talk to the people, use some data, and understand they're just Americans. We just happen to be Latinos, but we're Americans, have been in California for 250 years.
Great. Mary, you kind of touched on this point in your talk too, in commenting on what Tony Fauci's remarks at a press briefing and also the US Surgeon General's remarks that sort of carry some implicit framing of Black communities in the United States. You want to talk about that? Oh, you're muted. Let's unmute you.
Still muted.
There we go.
Started talking without unmuting. But the go-to explanation for why Black people are sicker and die younger than whites is that there's something wrong with the Black body. And we saw that replicated for a long time in the conversation about COVID. For a long time, it was rooted in notions of genetic susceptibility, which remain with us. That was part of the reason that I wanted to share the data from Cook County, Illinois, not because I think that we should dismiss race as simply a marker of poverty. It's much more than that, but because I want to make clear that this notion that it's something intrinsic is wrong, and that poverty is an important part of the context that David mentioned. So Tony Fauci, who's a very brave man and has been a voice for science throughout this pandemic, and the Surgeon General, who I'm less familiar with, but was very brave about needle exchange when he in his home state. They both invoked, problems with Black people. The Surgeon General sort of, I don't know where he thought this was relevant, that, stop smoking and drinking and using drugs. I mean, come on, this is an air, a virus that travels in the air. And Tony Fauci talked about, Black people are basically sick all the time. And now they're sick with COVID too. And it's really sad, but we need to understand it better. But let's for now, we'll try and take care of them. And leaving out what we've all been talking about is the very disparate opportunities for being exposed to COVID-19. The way you get sick and potentially die is by being exposed. And you've heard us talk about being exposed at home, being exposed on your way to work, being exposed in the workplace, and the fact that inadequate protections have been offered to people in all of these settings. And the advice that was given for Indigenous people, even the advice to wash your hands all the time. When I read somewhere that 30% of households in Navajo Nation don't have running water. People don't understand the circumstances under which people continue to live in this very wealthy country. And they go instead to problems that are within people's culture, belief systems, knowledge levels, and not talking about their risks of exposure. And I think that the media, went there with Dr. Fauci and Dr. Adams, and we've seen you begin talking more about the issues of exposure, and that was an important corrective.
Great. Well, we're just at the end of the session, so I'm afraid we're going to have to leave it there. If Dr. Bassett, you said you might, and Dr. Manson be able to join us in the Remo Social Hour next. So I encourage all attendees to go to that and find, unfortunately, Dr. Hayes-Bautista has to go off to another interview. But thank you very much to the three of you. It's been very informative. Thank you so much for your talks.
No, thank you very much.
And everybody should listen to Ruha Benjamin. She is absolutely brilliant.
She'll be speaking tonight at 6:30 Eastern in our Petruski lecture, part of the conference. Thanks again.
Thank you. Bye now.